to share with you a single center experience for patients with acute type A aortic dissection who had Malperfusion syndrome. They are also referred to as MPS patients. This complex aortic dissection can lead to dysfunction of organs and even the death from multi-organ failure. As shown in the figure, it includes malperfusion of brain, coronary, spinal cord, intestine, and the extremity. This case is from a 47-year-old male patient who had a type A aortic dissection with mesenteric artery malperfusion. And this enhanced CT show extreme compression of true lumen and diminished enhancement of intestine. So for this kind of patients, emergency surgery is required for patients with true lumen extremely small and multi-organ malperfusion. According to the guideline, the recommendation for MPS patients is immediate operative repair, which remain gold standard for MPS patients. However, with deep understanding of aortic dissection with organ malperfusion, more and more attention has been paid to the early evaluation and the management. So some scholars have proposed that early organ perfusion and delayed open repair can reduce perioperative mortality. So in our center, all patients with MPS patients are prioritized for interventional radiology, followed by delayed open repair. This flow chart shows a total of 777 patients, and only 60% of patients had Malperfusion syndrome, but the mortality rate was as high as 37% in MPS patients. So which was much higher than that of patients without MPS. And there are some characteristics in MPS patients. It includes male, higher BMI, history of vital organ dysfunction, and a longer wait for surgery. And they have disorders of coagulation and fibrinolytic systems. We found that FTP, D-dimer were independent risk factors of death from organ failure. What's most surprising is that MPS patients who underwent delayed surgery had a significantly lower mortality rate, and even similar to those patients without MPS. And these 5 years of follow-up show that compared with endovascular therapy alone, MPS patients who underwent delayed surgery had a better long-term survival. Therefore, we conclude that delayed open aortic repair has a favorable impact on the short and the long-term outcomes in patients with malperfusion. These two studies support our findings. It showed that MPS patients who underwent delayed open repair had comparable complications and mortality. But it also pointed out the increased risk of aortic rupture while waiting for open repair. And this article, published by the University of Michigan Hospital, shared their management experience of MPS patients in the past 20 years. It showed that hospital mortality and long-term survival were comparable to that of patients without malperfusion. Finally, there are two important questions that need to be clarified. The first question is about aortic first or branch first. We suggest that 5-hour rule can be referred to for the time of symptom onset to open surgery within 5 hours. Immediate operative repair can be adopted. Otherwise, delayed open repair would be considered. The second question is about MPS patterns. It's crucial for the choice of treatment. In our center, nearly 80% of patients wait longer than 5 hours for surgery. So we prioritize delayed surgery for MPS patients until they recover from malperfusion. After that, open aortic repair will be considered. In the end, we draw the following 5 conclusions. The first, delayed open aortic repair has a favorable impact on the short and the long-term outcomes. The second, organ failure is a leading cause of perioperative mortality in patients with MPS. The third, longer wait for surgery may result in an increased risk of rupture in MPS patients. The fourth, 5-hour rule could be referred to for patients with MPS, no matter it's aortic first or branch first. The fifth, the thrombolytic treatment for specific types of patients is beneficial. That's end of my speech. Please feel free.
So hello everyone, I'm really honored to be here today to present my topic. First, I want to introduce myself. My name is Thang Việt Lương, and I am a doctor from Vietnam. My research interest is atherosclerosis, heart failure, endovascular risk assessment, gastrointestinal disorder related to cardiovascular issues, metabolism disorder, and echocardiographies. I'm now working in the University of Medicine and Pharmacy of Vietnam from Hue City. It's a beautiful city in Vietnam. And I think today I'm here because I'm having an article that has published in Frontiers last month about the evaluation of the relationship between left atrial stiffness, left ventricular stiffness, and left atrioventricular coupling index in type 2 diabetes patient, speckle tracking echocardiographies. And I'm really happy to share this article with all of you. This contents of my presentations have a 4 parts. The first is background to the subjects and methods, 3 results and discussion, and 4 is conclusion. The first, as everyone knows, type 2 diabetes is one of the global health issues related to non-communicable disease, and the number of people with this condition is expected to surge by 35% from 2023 to 2035. Asia and Africa are 2 regions with the fastest growing rate, which can be explained by the increasing rate of obesity, unhealthy diets, sedentary lifestyles, and the changes in life of people in these regions. So diabetes is a major challenge in the communities because it's also one of the following causes of death worldwide, even in developing country and low-income country. And cardiovascular complication are the leading cause of mortality and disabilities in individuals with diabetes mellitus. So with the diabetes mellitus, increase the risk of cardiovascular disease, such as hypertension, coronary artery disease, and heart failure. And moreover, DM can directly impact the structure and function of cardiac muscle. And cardiac function often remains clinical silence in DM patient and is frequently undetected until the later stage of the disease. And even in a patient without symptoms, normal blood pressures and well-controlled DM, the silent increase in blood glucose impedes this optimal cellular glucose utilization, leading to cardiac fibrosis. And next slide, I will talk about the mechanism. The mechanism that the mechanism of cardiac fibrosis. The cardiac fibrosis is characterized by the increased extracellular matrix protein, collagen collagen deposition, disruption of cardiac cell artery, or restructuring of cardiac architectures, and is it a hallmark of DM-related cardiovascular changes. Changes in cardiac structure due to DM-related fibrosis are often associated with the elevation in myocardial stiffness. So patients without symptom, normal blood pressure, and well-controlled DM with the advance of imaging techniques and increase in awareness that heart failure is becoming more prevalent in DM patient, early detection of cardiac fibrosis changes is possible, and the cardiac magnetic resonance imaging is widely considered the gold standard for evaluating cardiac function. However, cardiac magnetic resonance imaging is also always readily available, especially in remote and economically disadvantaged area. So similarly, myocardial perfusion imaging in laboratory animal provides high-resolution imaging, but is impractical for continuous monitoring in clinical setting. So recent advancement in cardiographic imaging techniques is particularly as the speckle tracking echocardiography have allowed continuous, detailed, non-invasive, and really high resolution assessment of cardiac function in both clinicals and experiments testing, overcoming limitation in time and accessibility. Among these new ultrasound techniques, SD has emerged as a non-invasive biomarker for early detection of morphological and functional changes in heart. And the stiffness of the LA and the LV has been demonstrated to be crucial index for assessing and predicting various conditions such as hypertension, atrial fibrillation, coronary artery disease, and heart failure. And additionally, the left atrioventricular coupling index, LACIS, this is now considered one of the indices that can predict the likelihood of atrial fibrillation, heart failure, and other cardiovascular events early in life. So when recognized the significant role of LV stiffness, and LACIS, we have to decide that DM may influence the stiffness of the LV, LA, and the synchronization of LA and LVs in diabetes patients. There's a chance of the LACIS index. So we conduct a study to assess cardiac stiffness in DM patients in both the LV and LAs, as well as the impact of the DM on the synchronization of LV and LA, particularly in Vietnamese population, where there is an increasing change in DM incident that's used speckle tracking echocardiography. So to conduct this study, we divided the study population into two groups, the type 2 diabetes mellitus group and a healthy control group, and all of the patient is collected from the February in 2022 to the October of 2023, and the type 2 diabetic group comprise 52 consenting adults who meet the selection criteria and did not meet any the exclusion criteria. These patients were diagnosed with diabetes following the guidelines of the ADA and European Association for the Study of Diabetes. And exclusion criteria included hypertension, severe valvular heart disease, congenital heart disease, hypertrophic cardiomyopathy, dilated cardiomyopathy, ischemic heart disease, reduction, ejection fraction, heart failure, atrial fibrillation, pneumonia, and so on. And the control group consists of 59 healthy adults who underwent health screening, has no history of cardiovascular disease and diabetes, and we are age-matched to type 2 diabetes group. And the clinical collective include personal and family medical history and clinical variable obtained through direct interview and medical record. And the speckle, and we do the echocardiography by the Affinity 17 echocardiography machine from Philips Healthcare at the University of Medical Hospital. And the patient would do this, we do the speckle tracking analysis by performed using offline relapse software version 15. And during the ultrasound procedure, the machine stimulus recorded the echocardiogram alongside the echocardiographic image, and all echocardiograms included in the final data analysis were performed on patients in normal sinus stream. And these measurements are performed by an echocardiography expert who is independent of the research team and is unaware of the other patient information during the processing. And during the ultrasound examination, the patient were routinely made in the apical 4-chamber, 2-chamber, and 3-chamber views, and the image was scribed over through consecutive cardiac cycles and subsequently stored on a USB drive, and the speckle tracking analysis of myocardial strength was performed using offline relapse software version 15. And to assess the LV strength, a cardiac cycle was defined from the R way to the R way, and the selection of end-systolic and end-systolic frame was based on the closure of mitral or aortic valves, and respectively. And as the mitral annulus, choose reference points were poisoning and ones were placed at the aspect, and the process involved automated boring tracings with potential manual adjust if deemed necessary, and the LV global longitudinal strain was then calculated using 3 apical chamber view. Individual with comprised image qualities, insufficient body tracking, shortened views, and missing images were included from the analysis. With the left atrial stiffness, the initial report introduced the concept and validating the non-invasive estimation of LA stiffness was by Curry et al. And our study used 3 NDs is per equal to LASR, is per LASR radio, LAVIS per LASR radio, and the LA stiffness is calculated by the ratio of is per E phase to LASR. This formula has been widely employed in a number of studies to assess LA stiffness, and the LA fueling index is determined by the radius of mitral early diagnostic inflow peak velocity if to the LASR is per area radio. And additionally, recent studies have recognized the role of the LAVIS per LASR radio as equivalent to the aforementioned measure. With the left ventricle stiffness, is assessed using several parameters. It includes DWS in the diastolic response range, the radial of E per E points, and LV and diastolic volume, and E per LASR to LVDV. And the last is it defines the ratio between the LA and the diastolic volume and the LV and diastolic volume and LA and LV volume are measured as the same and the diastolic phase divided by the R weight on ECGs. So the LASI values are expressed at a percentage. What a higher LASIs indicate a greater dispersion between LA and LV volume at the end. These are diastolics, respecting the more significant impairment of LASIs. And on the statistical analysis was used by SPSS Statistics version 26. So after doing the research, I want to show you some reason and discussion. So in our study, when comparing the DM group and non-DM group, there were no significant differences in age, sex, BMIs, BSA, white circumstances, diastolic blood pressure, or alcohol consumption. And the selection aimed to minimize the influence of the factor on the assessed cardiac stiffness in these. And both the control and DM group exhibited normal blood pressure ranges, as hypertensive subjects were excluded to eliminate the potential impact on the study. So several publications have demonstrated the influence of age and obesity on LA and of stiffness, supporting our section criteria. And in the evaluation of LA morphology and functional parameter via echocardiography, we observed that the LASR, LASCT, and LASCD in these were significantly lower in the DM group than in the control group, and LVMI and the LVGLS in the DM group was lower in atrial, left ventricle, and the LASIs, and the various study have highlighted the impact of the DM on cardiac structure and function through multiple mechanisms. It's including impaired insulin metabolism signaling, mitochondrial dysfunction, increased oxidative stress, reduced nitric oxide bioavailability, or many other mechanisms. And to extend and to assess to understand the relationship between the multi-factor, we do the heat map, and it can show that we can see the positive correlation was observed between E's per LASR for LV EDV and E per LASR, which R was 0.45 with P is 0.001, and the ELS has a positive correlation with the E per A ratio and LV volume index. The LASI was also positive correlated with the LAVIs, and the LASI is also positively correlated with the index of LA and LV stiffness. So the LA stiffness and LV stiffness have been demonstrated to have prognostic value in predicting cardiac events such as atrial fibrillation and heart failure. And our findings suggested that these stiffness index change in DM patient before alterations in commonly used clinical index such as GLAVI. This hypothesis implied that LA stiffness and LV stiffness may not only have a prognostic value, but also serve as an early indicators of structure and functional cardiac changes in the DM patient. And this table shows the result of the losses for the LSI, LVGOS, LA stiffness indicator, LV stiffness indicator, and losses in patient with DM. And these three levels of LVGOS, adjusted for age, sex, blood pressure, and BMIs, have emerged as an identified risk independent risk factor for DM. And despite the independent prognosis value of LA and LV parameter for cardiovascular event, research into risk prediction model, enhanced model, discrimination, and reclassify cardiovascular risk, and to compare with individual LA parameter, the last determine early LA remodeling stages and has greater prognostic value in predicting cardiac events after adjusting for traditional risk factor. And in our study, the analysis also demonstrated significant acceleration in DM patient compared to the control group. Similarly, a recent study in DM and hypertension patients show an increase in losses in the DM group. And so the promising prognostic and early detection capabilities of LASI, we can be easily assessed through rapid and straightforward echocardiography measurement of the osmic prospect for spread clinical application in the future. My study have also some limitation. The first, we did not perform a comparative analysis across different ultrasound machine. We did not evaluate the impaction as a single time point. We would just do a single center study with a modest sample size, and we not include the potential influence of antidiabetes medication on cardiac function. So addressing these limitations in subsequent research will contribute significantly to new understanding of the in-future relationship between DM and cardiac parameter in medical fields. So up to conclusion, my presentation, I hope that you can have two messages to take home. The first is LV stiffness indicators. LV stiffness indicators and LASI are created in patients with diabetes mellitus than in healthy individuals, and their findings suggest a potential link between diabetes and increased stiffness in both the atrial and ventricular component of the heart. So thank you for your attention.
Cardiac toxicity of oleander seeds, and it is a case series which we studied in our medical college and hospital. So so we first introduced about the oleander. Oleander, it is basically known as kaner in India, and its name is Nerium oleander or indicum. It's an ornamental shrub, and basically it is found in tropical countries, belongs to Apocynaceae. Its leaves are whole, very green, leathery, narrowly elliptic to linear, and flowers are funnel-shaped, five-lobed, various colors, and from pink to red, white, and peach, and yellow in color. All parts of the plants are poisonous, and the poison that is present in these plants are oleandrin, which is a cardiac glycoside, and it is a poisonous to cardiac muscles, and it produces a picture similar to digoxin toxicity. In India, oleander plant is known since ancient time, and it is also mentioned in Charak Samhita, which is a Sanskrit version of old Ayurvedic book. It had been used in the past as suicidal, homicidal poison and criminal abortifacient. arrows poisoned with the oleander extract has been used by American tribes for hunting. So the ubiquitous presence of this plant and knowledge of its toxicity has caused it to be a common source of poison, and it is mainly used as self-harm, especially by the young people. Its seeds are pale yellow in color and hard like stones, and it has a covering of kernel and it content of glycosides. So here we can see the flowers and the seeds of this plant. The they are present in different colors: pink, yellow, white. So here we present a series of 3 cases of oleander seed poisoning which was manifested by vomiting, lightheadedness, and heart block. It is interesting that oleander poisoning can be fatal with relatively small amounts ingested. So the practicing physician should understand the potential lethal properties of the oleander and its availability throughout the world. So first case the case first was a 17-year-old female who was admitted in the emergency ward with vomiting and lightheadedness 18 hours after the ingestion of common oleander seeds, and she had ingested around 3 seeds. The patient was not. The patient was not.
We are not able to see your slides. Still on the first slide.
Sorry.
Your presentation is still on the first slide. Can you please share your current slide?
Yeah. It is case 1. Is it visible or not?
No, we are able to see the first slide.
Okay. Okay. Now, next slide.
No, we're still on the first slide.
Okay. Now it is visible. The second one. Hello.
No, Dr. Kiran. We've lost the entire presentation.
Okay. Is it visible?
No, Dr. Kiran.
Is it visible?
No. Yes, now we can see the second slide.
Okay. Now slides are changing.
Yes.
Now it is visible.
Yes, yes.
Okay.
Continue.
Sorry for the mistake. Okay. So we will resume from the first case. So A 17-year-old female was admitted in the emergency ward with vomiting and lightheadedness. 18 hours after ingestion of common oleander seeds, she had ingested 3 seeds, and the patient was non-smoker, non-alcoholic, and she had no history of any drug allergy and was mentally sound. And on initial examination, her BP was 130 by 80 mmHg, but pulse was irregular and it was 55 per minute. And other general physical parameters were normal, and chest and lungs were clear on auscultation and percussion. And on previous examination, there was irregular rhythm with shocked S1 and normal audible S2 over the cardiac apex. On ECG, basically,
Dr. Kiran, can you please turn on your video if possible?
sorry?
Can you please turn on your video?
Yeah, sure. Okay.
Yes, thank you.
Oh. On cardiovascular examination, it was a regular rhythm with soft S1 and normal audible S2 over the cardiac apex. And we have 2 ECGs. We have 2 ECGs. The first ECG is showing at the time of admission, and the second ECG was at the time of discharge of the patient. So we can see in the first ECG, we can see the prolonged PR interval with varying degree of AV blocks, normal QRS duration, and T wave inversion in V2 to V6, and at the time of discharge, she was discharged after 3 to 4 days of hospitalization, and she was discharged, ECG showing the sinus bradycardia, and during her hospitalization, she was totally asymptomatic, but the bradyarrhythmia and bradycardia, it was treated by atropine and isoprenaline, and yeah, patient was given 0.6 mg of IV atropine sulfate and plus orciprenaline 10 mg 3 times a day. And after 3 days, the patient was discharged on request with sinus node dysfunction and varying degree of AV blocks. And in the case 2, again, a young female referred from the local district hospital. He was presented in emergency ward with history of ingestion of 5 seeds of oleander. And on initial examination, she was conscious and oriented to time, place, and person. And her BP was 98 by 58 mmHg, and pulse rate was 65 per minute and having irregular rhythm. Other physical parameters were normal, and her chest and lungs were clear to auscultation and percussion. Now, on examination, it revealed an irregular rhythm with soft S1 and normal audible S2 over the cardiac apex. And her ECG at the time of admission again shows prolongation of the PR interval with AV block. It was 3 raised to 2 AV block before the treatment, and after the treatment, the ECG showing inverted P wave and T wave flattening in the inferior leads, and STTT changes in lead V1 and V2 after the treatment with the atropine and the orciprenaline. This case was also treated with IV atropine and orciprenaline, and she was also asymptomatic throughout the hospitalization, and she got discharged on request on day 3, and both the patients didn't come for follow-up. And case 3, a 23-year-old female patient referred from local district hospital was admitted in emergency ward with history of 3 seeds of oleander ingestion, followed by vomiting and headache. And at the time of admission, she was conscious, oriented to time, place, and person, and her pulse were 52 per minute, and blood pressure was 120 by 80 mmHg. And there was no history suggestive of smoking and alcohol intake, and other physical parameters in cardiovascular examination were normal. She was also given IV atropine sulfate and isoprenaline. And the ECG, the first ECG again shows, first and second ECG again showing sinus bradycardia. So this ECG was at the time of hospitalization, and the second ECG showing at the time of discharge. And all the 3 cases, we presented here were asymptomatic during their hospitalization and were treated with atropine and oxypromethrin, and they didn't come for follow-up because they were asymptomatic. So they asked for discharge on request, and they were discharged with ECG showing bradycardia and varying degree of heart loss. So yellow oleander, it is a commonly plant in most part of India, and all parts of the oleander plants are poisonous. Even smoke of burning the twigs, they all are poisonous. One of the most debated topic of the oleander poisoning is the lethal dose of the seeds and how the seeds were ingested. The physical form it is taken and its relation to the severity of symptoms. Lethal dose of oleander seeds may be between 4 to 8, and all three cases we presented have taken 3 to 5 seeds and shown ECG change. It is consistent with the studies like Srihan et al. Conducted on 1985 and in 1988. Yellow oleander is predominantly cardiotoxic but can also produce GI and neurological symptoms. Cardiac toxicity is the hallmark of the oleander seed poisoning. Basically, cardiac glycoside, oleandrin, it inhibits sodium potassium ATPase pump, which results in increased intracellular sodium and potassium, sodium and calcium. The intracellular hypercalcemia leads to spontaneous depolarization and hence increased arrhythmogeny. The rhythm disturbances varies from simple bradycardia to complex bradycardia. Morbidity in oleander glycosides toxicity is due to cardiac effects, as those with ECG changes needed some form of intervention. We use mostly pharmacological intervention, and drugs used by us were atropine and oxypromethrin. We did not use digoxin antibodies because of its unavailability in a hospital, and our hospital didn't have facility for cardiac pacing. Other treatment methods are aimed at removing the toxic substance from the stomach by emesis. But a special concern must be given to a patient with bradycardia before emesis is induced because of the possibility of a vagal reaction and worsening of bradycardia. Unabsorbed glycosides may be bound to some extent depending on the particular glycoside by various binding agents in the gut. These agents theoretically should be more effective in absorbing less polar glycosides such as disotroxin than the polar glycoside like disoxin. The use of these agents is not thought to have substantial value in the treatment of advanced toxicity, and they were not used in our patient. Role of activated charcoal. Activated charcoal has been shown to be useful in preventing further absorption of the cardiac glycoside by interruption of intrahepatic circulation of the glycoside, but it was not used in our not in our patient, because they were all brought after 15 hours of ingestion of the toxin, and due to the unknown status about the intrahepatic circulation of the oleander glycosides. So, on conclusion, it is interesting that oleander poisoning can be fatal with relatively small amounts ingested. So, practicing physicians should understand the potential lethal properties of the oleander seeds and its cardiac effects, its easy availability and well-known toxicity that is used for self-harm throughout the world. So, this is from my side. Thank you.
I'll be presenting the novel myosin binding protein C mutation in Indian inherited cardiomyopathies. I first of all want to thank the organization for giving me the opportunity to present my research work at the second international webinar on heart and cardiovascular diseases. I hope the slides are visible.
Yes, Dr. Rani.
I'll be presenting the myosin binding protein C. This myosin protein. myosin binding protein C gene. It is located at the chromosome 11. This one is of 21 kb in size and 35 exons. It is a key constituent of thick filament. It's arrayed transversely across the C zone of A band of sarcomere. It gives the structural stability by binding the thick filament myosin and elastic filament titin. This phosphorylation of myosin binding protein C modulates the contractions by limiting the cross-bridge interaction between the actin and myosin. So it believed to play both structural and regulatory role. This myosin binding protein has 3 isoforms. 2 are in the skeletal muscle and 1 in cardiac muscle. All 3 shares a common 7 immunoglobulin region and 3 fibronectin type domain. But the cardiac isoform has a unique IgI domain at the C0 near the N terminus and 4 distinctive phosphorylation sites and an exclusive 25 base proline-rich residues in insertion at the C5 domain. The mutation myosin binding protein C, one of the most frequent cause of cardiomyopathies. Cardiomyopathies are the disease of the heart muscle which changes the morphology of the heart. Based
I'm
on
sorry,
this,
Dr. Rani, can you please turn on your video?
pardon me?
Can you please turn on your video? Yes, we can see.
Cardiomyopathies are based on this morphology. It is classified into 4 major categories. One is hypertrophic, dilated, restrictive, and arrhythmogenic right ventricular cardiomyopathies. The first 2 I'll be discussing, hypertrophic and dilated cardiomyopathies. In both cases, it's affecting the pumping efficiency of the heart. Clinically, genetically, it is heterogeneous, variable penetrance. In the case of hypertrophy, it is the thickening of the left ventricle. Here it is the dilation and enlargement of left ventricle. Here it affects the diastolic function. Here it affects the systolic function. Then you see most of the mutation in sarcomeric genes are the primary cause for heritable cardiomyopathies. R2Q mutation in myosin heavy chain was the first mutation identified in SCM patient. After that, hundreds of mutations have been identified in sarcomeric genes. This identified mutation, 75% of them are from heavy chain and myosin binding protein C, and only few, 10% were found in troponin compound and tropomyosin. And only very rarely mutations were identified in actin and light chain, myosin light chain. That too, when we do a large cohort study, the majority of disease-causing mutations were unique, rare, and private. Only occurs in families. Mostly positive mutations were validated through co-segregation and linkage analysis. Unfortunately, not many studies were carried out on Indian population. So, Indian population genetic etiology remains largely unknown. That is the reason we carried out this study. Here we analyzed 115 HCM and 127 DCM cases against 197 healthy controls. These are the characteristic features. These are the areas where we collected our samples. Our study revealed 34 genetic variations in myosin binding protein C gene. Of this common variations, even we compared with the other population, the frequency is here. Out of this 34 genetic variations, we identified 19 novel ones. These novel ones we have submitted to NCBI database. As I said, we observed 34 genetic variation in myosin binding protein C gene. Of this, 27 were exonic variations. This 27 exonic variations, we found 16 missense mutation and a splice site variation. 5 missense mutations were exclusively found in HCM and 4 of them were found in DCM, and 7 of them found in both HCM and DCM. All the 16 missense mutations were absent in controls. Mutation in myosin binding protein C, as I said, we found 16 missense mutation. Out of the 16 missense mutation, 7 were predicted pathogenic by polyphene 2 unstripped bioinformatic tool. Then we saw this 17 mutation. It is conserved across the species, and even it is co-segregated along with the disease in the families. It accounted for 8.7% in HCM and 6.3% in DCM. Interestingly, we found compound mutation, that means more than one mutation in myosin binding protein gene itself in a patient. We found 3 HCM patient and 3 DCM patient carrying more than one mutation in myosin binding protein C with a severe disease phenotype. Of this HCM, these 3 are HCM patient. One is 51-year HCM. He showed allelic heterogeneity by having one splice site mutation, one synonymous, one silent mutation, one non-synonymous mutation. Here, 53-year-old HCM patient carried 3 missense mutation, and 49-year HCM patient carried 2 missense mutation and a silent mutation. This is silent and 2 missense mutation. Same way, DCM patient, all 3 of them carried a compound mutation, and one is having one 5' UTR region and one non-synonymous, 2 non-synonymous mutation. Here, again, this patient carried 2 missense mutation. Again, here you could see 2 missense mutation and a silent mutation. This study, this present comprehensive study on myosin binding has revealed both single and compound mutation in myosin binding protein C and their association with disease in Indian population with cardiomyopathies. Certainly, our findings may perhaps help in initiating diagnostic strategies and eventually recognize the target for therapeutic intervention. This study, published in the year 2023, the Journal Pharmacogenomics and Personalized Medicine. See, compound mutation is not new for our population. Previously, we reported the compound mutation in heavy chain. One is alanine to threonine and another one is valine to methionine. These 2 mutations we observed in 2 patients. One is 55 years old HCM and another one is 45 years DCM. HCM and DCM patient are 2 different phenotypes but carrying the same mutation. We were wondering how the same mutation can produce 2 different phenotypes. Then we found, interestingly, the DCM patient also carried allelic heterogeneity by having some more mutation, additional mutation along with this 2 mutation. And additional mutation is one is splice acceptor site mutation and another one is silent mutation. So it indicates the phenotypic plasticity here. This patient daughter also has a mutation, but she is asymptomatic and mild DCM. And family history of sudden cardiac death also we noticed. Here, her sister, she died at the age of 65. So the onset and severity are highly variable within the family. That could be the lifestyle and environmental factor also a contributing one. These 2 mutations, we even made the homology model and superimposed the mutant versus the native. The first mutation A to T, we didn't see much variation. Here, the valine to methionine, it showed RMSD value high. Root mean square deviation is very high here. Then we saw the non-bonding interaction. We know that non-covalent interactions are the heart of stabilizing the protein structure. So each mutant disturbs the structure differently. The valine to methionine, here, it disturbs a critical network of non-bonding interactions by producing a hydrophobic interaction with the mutant. Leucine 352 produces a hydrophobic interaction with the mutant methionine. So that result in reducing the spatial distance between the other hydrophobic interactions that produces a strain or deviation in the structure. That could be the reason for the more deviation in the structure. This work I have presented at the Bangalore Medical College and Research Institute and received a severe Women's Researcher Award for it. Not only this compound mutation in a same gene, even we found this coexistence of diagenic mutation in both the thin and thick filament of sarcomere genes, which leads to a severe hypertrophic cardiomyopathy in South Indian familial hypertrophic patient. When we screened the tropomyosin, we found serine to leucine mutation in 2 HCM cases. One patient is 44 years and another patient was 65 years old. This mutation co-segregating with the disease, along with the disease in the families, both the families. But what happened? These mutations were completely absent in our control. But this 44 years old patient showed more severe phenotype with a poor prognosis, a family history of sudden cardiac death. But the patient too, he developed the symptoms very late. We wonder what could be the reason. Then we screened other sarcomeric genes. Then we found additional mutations in that the first patient, 2 missense mutation in heavy chain and 1 mutation at the branch point of actin gene. So we strongly suggest the coexistence of the diagenic mutation is rare, but it leads to a severe hypertrophy in South Indian familial hypertrophy patient. Coming again to the myosin binding protein C, we published a 25, we first found a 25 base pair deletion that is in the intron 32. That is associated with cardiomyopathy, an increased risk of heart failure in Indian population. This 25 base pair deletion deletes the exon 33. We screened 321 individuals having cardiomyopathy against 238 controls, including 33 postmortem cases. This many places we collected the samples and we found high frequency of deletion in cases. And we even found 3 patients having homozygous 25 base pair deletion. But sadly, all 3 died. 2 were died less than 2 years or 3 years of age. So homozygous showed that severe early onset and patient they don't survive. These mutations were got from this postmortem cases. And again, we replicated the study because the high frequency made us to replicate the study with more samples. We again analyzed 446 additional cardiomyopathy samples versus 466 controls. These are the places, again, we collected the samples. And these are the characteristic features of patients, group 1 and group 2. Together, we found high frequency of deletion in cases. The high frequency of deletion in cases wanted to study the population stratification, because to know whether this frequency, deletion frequency is due to disease association or it is difference in the ancestry which shows that high frequency. Therefore, we analyzed this 456 cases versus 338 controls using 50 ancestrally informative markers. And we found this stratification, all cases and controls are falling together. That means it is associated with the disease. The cases and controls are from the same place. Even if we included the European samples, cases and controls are falling together, Indian cases and controls. European samples are falling apart. That shows a disease association here. Even we studied the family members having this 25 base pair deletion. And we found, these are the characteristic features of them. We found it is a late onset, mild hypertrophy in the early age, and also incomplete penetrance. Late onset, in the third decade, it started showing. To understand the risk induced by the deletion, we analyzed the RNA and protein from the endomyocardial biopsies specimens of two young patients. One is 25 years and another one 32 years old. And we could found two transcripts. One is with this exon and without that exon. This is a deleted one transcript. But we could not isolate the mutant protein. That could be due to UPS system, ubiquitin proteasome system. That means it is the protein degradation machinery which deletes this mutant protein. So it gives a lot of workload for this. Lifelong additional workload it imposes to the heart. So to determine whether the altered protein could distort the normal architecture of the sarcomere, we express this MIC tagged altered protein along with the wild type protein in a neonatal rat cardiomyocyte. Staining with antibodies to this showed a high disorganized or diffused pattern of sarcomeric architecture. As a result of aberrant incorporation of altered protein. So altered protein get incorporated, it distort the structure of the sarcomere. You could clearly see here. Again, expression of this protein in neonatal rat myocyte shows this structure, how it is getting distorted or disarrayed. Even we screened all over India to know the frequency of this 25 base pair deletion. So we screened 6,273 samples. They are from 107 ethnic population. We found 279 heterozygous deletion that accounts for 2 to 8% deletion. We wanted to know the global distribution of this 25 base pair deletion. So additionally, we screened 8,358 samples. 2,085 were from outside India, from 70 population and 26 countries. Surprisingly, we could see this deletion only in Asian patient population. Outside, it is not occurring. This study published in Nature Genetics. Thank you. Thank you.
Residency opportunity in the USA. I'm very glad to be participating in this webinar with experienced professionals from all over the world. My topic of presentation today is the impact of contemporary antiretroviral drugs on atherosclerosis and its complications in people living with HIV. So HIV infection has now become more manageable thanks to early diagnosis and access to modern antiretroviral therapy. This shift in trend highlights the rising importance of cardiovascular diseases as significant complications in people living with HIV. With more people getting access to newer HIV treatments, there is a need to understand the long-term effects of these drugs. So our study aim, with this systematic review, we set out to assess the influence of newer antiretroviral drugs, especially the integrase strand transfer inhibitors and protease inhibitors on atherosclerotic cardiovascular disease in people living with HIV by compiling evidence from the latest available research findings. Methods. For our search databases, we conducted an extensive literature review using the databases PubMed, PubMed Central, and Cochrane.
Your slides are not moving. Your slides are not moving.
Sorry. Can you see it now?
Yeah, yes. Yes, Abhijit.
Okay. So for the search databases, we use PubMed Central, and Cochrane Library following the PRISMA 2020 guidelines. Eligibility criteria. The recent studies that were published between 2018 to 2023 in the English language, focusing on the impact of integrase strand transfer inhibitors or protease inhibitors on lipid and metabolic parameters in adults with HIV infection, were selected for our review. All the articles selected were critically appraised using the appropriate quality assessment tools. And ultimately, 7 cohort studies, 7 cross-sectional studies, and 1 randomized control trial were included in this review. The key findings of the selected studies have been simplified here. The major risk factors we considered in this review were dyslipidemia, weight gain and obesity, hypertension, and metabolic syndrome. The risk of dyslipidemia is highest with protease inhibitors, followed by integrase transfer inhibitors and non-nucleotide reverse transcriptase inhibitors. The risk of weight gain and obesity is greatest with integrase strand transfer inhibitors, followed by protease inhibitors, and then by non-nucleoside reverse transcriptase inhibitors. The risk of hypertension is higher with integrase strand transfer inhibitors and protease inhibitors than with non-nucleoside reverse transcriptase inhibitors. The risk of metabolic syndrome is greater with INSTIs compared to NNRTIs. The role of HIV infection in the pathogenesis of atherosclerosis has been well established. We all know that the inflammation in HIV infection is an important risk factor for the atherosclerosis development. HIV infection increases the risk of atherosclerotic cardiovascular disease through 3 possible mechanisms: the chronic inflammation and immune dysregulation due to the underlying viremia, the greater incidence of traditional cardiovascular risk factors in this particular population, and finally, the potential side effects of the antiretroviral drugs. This link has been supported by higher levels of inflammatory biomarkers like oxidized LDL levels being higher in the HIV infected individuals compared to the HIV negative individuals. The use of statins might help lessen this increased risk. Risk of dyslipidemia. The dyslipidemia in people living with HIV can be HIV related or ART related. Either way, hypertriglyceridemia is the most common type of dyslipidemia. Integrase strand transfer inhibitor based regimens appear to have lower risk of dyslipidemia compared to the protease inhibitors. This is thought to be due to reduced stress on the endoplasmic reticulum. Among INSTIs, dolutegravir had a lower risk than elvitegravir and raltegravir. Some studies have actually linked the use of protease inhibitors to atherogenic dyslipidemia, but not to the LDL-related dyslipidemia. So, close monitoring and lifestyle adjustment are crucial for managing dyslipidemia in patients on antiretroviral therapy, particularly those on protease inhibitors. Risk of weight gain and obesity. Several studies have linked INSTI use to higher risk of weight gain and obesity. This risk is higher in patients who are underweight at the time of treatment initiation. Although it is postulated that this increased risk could be due to the better immune reconstitution in these patients with advanced infection, the exact mechanisms needs to be studied further. Within INSTIs, elvitegravir appears to be associated with lower rise in BMI compared to dolutegravir or raltegravir. The BMI increase with protease inhibitors is moderate, although comparable to that of NNRTIs. Risk of hypertension and metabolic syndrome. Studies suggest that integrase strand transfer inhibitors and protease inhibitors have a higher risk of hypertension compared to NNRTIs. The possible explanations for this association with INSTIs include metabolic changes like weight gain, dyslipidemia, insulin resistance, and oxidative stress. Newer newer protease inhibitors have been shown to have lower risk of hypertension compared to older protease inhibitors. Coming to the risk of metabolic syndrome, dolutegravir-based regimens have twice the risk compared to NNRTI-based therapy. The risk of lipodystrophy. The contradicting evidence regarding the link between dolutegravir exposure and lipodystrophy could be explained by reverse causality. This means that the doctors might be more likely to prescribe dolutegravir to patients who already have signs of lipodystrophy. This could have led to a mistaken observation that dolutegravir led to lipodystrophy in these patients, when in fact the patients with pre-existing lipodystrophy were simply more likely to receive dolutegravir. Risk of cardiovascular disease. Boosted protease inhibitor regimens and long-term use of protease inhibitors have been reported to increase the atherosclerotic cardiovascular disease risk. Conflicting evidence exists regarding the cardiovascular risk associated with INSTIs. Some studies indicate that there is an increased risk with INSTIs, while others indicate there is no increased risk. Balancing the need for treatment with potential drug interactions and polypharmacy is a challenge, especially in the aging population with HIV. The management of these complex healthcare needs of people with HIV requires a multidisciplinary approach. Limitations. Even our review was not without any limitations, like heterogeneity in the outcome measures. For example, some studies use carotid intima medial thickness as a marker for atherosclerosis, while some use plaque number. And there are sample size limitations in the studies and exclusion of specific patient groups like pregnant women. Conclusions. Clinical implications. The use of contemporary ART regimens requires careful cardiovascular risk assessment and management to prevent adverse cardiac outcomes in people living with HIV. During regimen selection, we should consider mitigating the cardiovascular risk without compromising the HIV treatment efficacy. Future research directions. We think further research into the mechanistic links between modern ART and the overall atherosclerotic cardiovascular disease risk is needed. Delving into the risks that these individual drugs pose can help us modify regimens better to the individual patients.
Our systematic review and meta-analysis and non-pharmacological interventions for preventing rehospitalization among patients with heart failures. So heart failures affects over 6 million people in the US and more than 550,000 new cases diagnosed annually. As the leading cause of hospitalization among people aged 65 and older. Also, heart failure patients face the highest rates of rehospitalization, within the significant percentage returning to the hospital within 30 days of discharge. And actually, when we reduce this readmission rate, it's very important to improve. It's very important to improve patient care and reducing health care cost as well. So current gap in heart failure management. So we know that despite the significant progress in heart failure management, it remains challenging because we know that some evidence-based strategies improve self-care and decrease hospital admission among heart failures. Although non-pharmacological interventions, have been evaluated to reduce heart failure-related hospital readmissions, systematic research and meta-analysis comparing the effectiveness among these studies are not well established. And current heart failures guidelines recommend primary care practitioners should provide comprehensive education that focuses on self-management, the skills and knowledge to patients with heart failure. Non-pharmacological interventions, including home visits, intensive technology-based monitoring, and inpatient education, are being used to improve patient care and reduce the healthcare burden. Interventions focused on hospitalizations reductions are necessary to facilitate improve patient and healthcare provider outcomes, and also health care systems outcomes for heart failures. So the objective of the study. So given the need to improve care and reduce hospital admissions, we conducted systematic review and meta-analyses to evaluate the body of evidence regarding non-pharmacological interventions designed to mitigate the heart failure readmissions. And the systematic review and meta-analyses aim to assess the efficacy of non-pharmacological interventions on hospital admission in patients with a heart failure to compare their effectiveness with that of a standard care. So we conducted a systematic review and meta-analysis following PRISMA guidelines, and we searched for databases including PubMed, Cochrane Library, and Web of Science, and also CNAM. And the inclusion criteria were randomized controlled trials involving patients over 18 of age with heart failures, published in peer-reviewed journal in English. And also we use random effect model for data analysis to accommodate the variation across the study result. So the findings, our okay, so our studies covered more than 2,000 heart failure patients, and the intervention of this study were classified into four types: multimedia education, phone-based education, based self-care, and also pre and post-discharge education for follow-up. For multimedia, for multimedia education intervention, we had two studies, okay, that implemented multimedia education intervention designed to reduce rehospitalization admissions. And the interventions significantly reduced the risk of readmission for 12 months following their readmission. Also, the one study used phone-based interventions, and such as using short message service and structured telephone support, okay, to improve all cause of hospitalization at 180 days of follow-up. And the short message service and group received a short message that explained the symptoms of heart decompensation, and the the structure group received one structured phone call from research nurse within 30 days after discharge. And the result showed that short message service and structured telephone support significantly reduce or cause readmission in 180 days of follow-up. Also, we had 6 studies that use education-based self-care interventions to evaluate intervention through education. And the author examined the impact of tailored education intervention designed for patients with mild cognitive impairment on 30 days and the readmission rate was within 30 days. And the intervention showed that patients who used the intervention showed significant reduction in hospitalization within 30 days after follow-up compared to those who used the usual care. Also, we had 5 studies that use pre and post-discharge education interventions and investigated whether a pre-discharge education program combined with one post-discharge follow-up reduced readmission in patients living with heart failure. And at 12 months after hospital discharge, the intervention group had fewer hospital readmission than or compared to those who use usual use. And the reduction was significant. So in our meta-analysis result, we evaluated the outcomes from 14 studies, including more than 2,000 patients. And this study provided data and rehospitalization rate. And we found that patients who received non-pharmacological interventions had 46% lower odds of rehospitalization compared to those receiving usual care, within the odds ratio of 0.54. And this difference was statistically significant as evidenced by the p-value less than 0.001. So our systematic review and meta-analysis aim to assess the effectiveness of non-pharmacological interventions on hospital readmission and person with heart failures. And most non-pharmacological interventions were effective in reducing readmissions. However, the success varied based on the type and durations of interventions, which range from 2 months to 12 months. All had a significant difference on our outcomes. Although the interventions types varied, they commonly include education about heart failure, self-care management, medication adherence, diet adherence, and exercise device, and also self-care skill. And multidisciplinary approach involving nurse, physician, and social worker and pharmacist was often employed. Key takeaway. So the key takeaway from our study is that hospitalization can be significantly reduced with post-discharge intervention that focus on education and self-care management. So the implications of our study to clinical practice, and based on our findings and results, we found that non-pharmacological intervention should be considered as a key component of discharge planning for heart failure, because patients, they may have be discharged with medical management, but they may find or miss the non-pharmacological intervention or discharge or instruction, which is very important as one of the essential components to be in discharge summary. And healthcare providers need to focus on personalized intervention strategies tailored to individual patients' needs and local healthcare settings. So for future research directions, we looking ahead, and we need further study that identify which component on non-pharmacological intervention are most effective. And research should also explore the integration of this intervention with pharmacological treatment to maximize patients' outcomes. Okay, thank you so much for your attention. I'll be happy to take any questions from you. Thank you so much.